Hi guys, with you Dr. Muhammad Hamid, an ECVMG certified physician, and I wanna talk a little bit about coronary artery disease in the cardiovascular system of the USMLE Step 1 exam. So about the coronary artery disease, first it is subdivided into angina and the myocardial infarction. So you know that angina, there is no death of the tissue. The difference between angina and myocardial infarction essentially in there is necrosis of the tissue and then liberation of cardiac enzymes into the circulation. So in angina, no necrosis of the tissue, while in myocardial infarction there is necrosis. Is the main difference between them. The angina, essentially you have chest pain due to ischemia of myocardium due to secondary to coronary artery narrowing or spasm. There is no necrosis. So it is further subdivided into stable angina, unstable angina, and vasospastic angina. For the stable angina, you have always an atherosclerosis, more than 70% occlusion of the vessel, and you have exertional chest pain. So at rest there is no pain, but when you do exertion and put some strain on the heart, you will have the pain, and when you rest the pain is off. So this is a stable angina, means that you have pain on exertion, and it is resolving with either rest or nitroglycerin. So for unstable angina, you have thrombosis with incomplete coronary artery occlusion, and you have increased frequency or intensity of the chest pain, but at rest. So if your patient came to complaining of typical chest pain at rest and increasing the frequency of these attacks, so he is in the category of unstable angina. But you have to make sure that there are no elevated biomarkers of myocardium, such as troponin and CKMB. This is versus non-ST elevation, myocardial infarction, non-STEMI, where there is elevation of biomarkers of myocardium. The third type, which is some less common, is vasospastic angina. The former name of it was the Prinzmetal angina or a variant angina. This also occurs at rest. It has nothing to do with exertion, but it occurs secondary to coronary artery spasm. So the vessel lumen is nothing. There is no atherosclerosis blocking it or nothing in the vessel wall, but you may have a precipitating factor. There are a lot of precipitating factors such as tobacco smoking, and there are a lot of drugs such as cocaine, amphetamine, alcohol, and triptans. So these kind of precipitating factors, tobacco smoking, again cocaine, amphetamine, alcohol, and triptans, these may cause constriction of the coronary vessel, and so the blood supply is cut off. So you have vasospastic angina. This has nothing to do with exertion. Again, it occurs at rest. And when you do an ECG, you will find that a transient ischemic ST it changes. So you will capture this only when the patient have the attack. So if the patient does not have the attack, ECG will be normal. So only if the patient got the attack, you will notice the transient ischemic ST changes. So for the treatment, you may give the patient something that will vasodilate the coronary artery, such as calcium channel blockers and nitrates, and you have to go through some kind of programs for smoking cessation if applicable. The other type is myocardial infarction. It further subdivided into non-STEMI and STEMI. Most often it is due to rupture of the coronary artery atherosclerotic plexus. So you are progressing from angina, stable and unstable angina, due to atherosclerotic plexus obstructing the lumen, but not completely. But if the atherosclerotic plate rupture, it will lead to an acute thrombosis. So the acute thrombosis will lead to myocardial infarction and the complete shut of the blood, and the biomarkers of CKMB and the troponin will go up. So it first subdivided into non-STEMI and STEMI. So both of them occurs at rest. You have MI, so it occurs at rest. So for the troponin, it will be elevated. Unlike unstable angina and stable angina, there is no elevation of troponin, but in non-STEMI and STEMI there is elevation. But you may ask yourself, what is the difference between them if the troponin is elevated in both? So it is the level of the infarction. So for STEMI there is transmural infarction, all of the muscle is infarcted, but in non-STEMI there is subendocardial infarction, only the subendocardial part of the muscle myocardial wall is infarcted. So this reflects on the ECG changes. For the SCT elevation myocardial infarction, you will, from its name, it is SCT elevation, you may find pathological Q waves, but in non-STEMI you will find SCT liberation or T wave inversion. So, and there, the next topic is ischemic heart disease manifestation. So you have ischemic heart disease, different kind of ischemic heart disease, angina, MI, STEMI, non-STEMI. So you the effects of them. So first, something called the coronary syndrome. So distal to the coronary stenosis, vessels are maximally dilated at baseline. So if you have a stenosis in the vessel and the vessels are dilated after the stenosis, so the vessels after the stenosis here is dilated to maximize the outflow of the blood. So if you give vasodilators such as dipyridamole, so there will cause vasodilation of the other normal vessels. So the diseased vessels are vasodilated to compensate and increase its blood supply, but you may stress faster the heart and give another vasodilator that will vasodilate the normal vessels. So it will shift the blood to the well perfused area of the heart. So this will exacerbate ischemia in the myocardium. Perfused by stenosed vessels, you have shunted the blood away from this stenosed vessels. So this is a basis for vasodilator tests such as dipyridamole. So this is vasodilator stress test, relies on the differential flow to detect potential ischemia. And there are some adverse effects of this, rarely may cause coronary steal and true ischemia, and you put your patient at danger by doing this test. So this is for coronary steal syndrome. Another thing is sudden cardiac death. The patient who have ischemia may go directly into sudden cardiac death, which means an unexpected death within 1 hour. So I've seen a lot of patients who may come and be arrested within 1 hour of their complaint. And the most common cause is a very high yield point. It is the most common cause for sudden cardiac death is lethal arrhythmia. The most, for example, in ventricular fibrillation, very lethal arrhythmia is ventricular fibrillation that way may not be improved with DC shock or CPR. So this is the most common cause for sudden cardiac death. This is associated with the sudden cardiac death. There are many causes for sudden cardiac death. So coronary artery disease constitutes up to 70% of them, but there are other causes such as cardiomyopathy, hypertrophic cardiomyopathy, or dilated cardiomyopathy may cause sudden hypertrophic cardiomyopathy in the young athletes. A genetic condition, dilated cardiomyopathy, may be viral or some many other causes. So this also may cause sudden cardiac death. And channelopathies such as long QT syndrome may be genetic condition and precipitated by antibiotic, antidepressant, and antipsychotics, and some kind of ion channelopathy, also called the Brugada syndrome. You don't have to know much about it, but it's essentially kind of hereditary channelopathy due related to sodium. And so these are all kind of different diseases. You may prevent them if needed with implantable cardioverter. So it will give a DC shock immediately if it is noticed any kind of arrhythmia. So the other downside to the ischemia is the patient transitioning from acute ischemia to chronic ischemic heart disease or chronic heart failure. So progressive onset of heart failure of many years, you will have cumulative damage over the heart. You may have cumulative damage, minor damage that occurs over so many years that will accumulate to give you heart failure over many years due to chronic ischemia or myocardial damage. So, and on the level of cells, there is myocardial hibernation and myocardial stunning. Both of them are LV systolic dysfunction, but hibernation is in the setting of chronic ischemia. Chronic ischemia is hibernation, but stunning in the setting of acute ischemia. So they myocardial hibernation, potentially reversible LV systolic dysfunction in the setting of chronic ischemia, but myocardial is stunning also transient LV systolic dysfunction, but in a setting of acute ischemia. And for the evolution of myocardial infarction, you have to know that the order of the most commonly affected vessels, you have the left anterior descending left coronary artery here, coming here, and the first subdivided into left circumflex artery here, and the left anterior descending artery, and this is the right coronary artery. These are simplification of the vessels of the heart. So the most commonly occluded is the left anterior descending artery, and this is the most dangerous because it supplies the left ventricle, which has the function of pumping blood. So the patient may go into sudden cardiac arrest if he has a lead infarction. So the left anterior descending artery most commonly is the second is the right coronary artery, and the third affected vessel is the circumflex vessel. So the symptoms may be typical symptoms such as severe retrosternal pain and pain in the left arm or jaw. And I've seen a lot of patients coming with rare symptoms. I've seen a patient coming with hiccup only and progressed to STEMI, and came with other came with cardiac syncope. The patient may came with fatigue or shortness of the breath only. The patient may complain of diaphoresis, nausea, vomiting. So you have to maintain a high level of suspicion for this for the MI in the patient of the typical age and typical risk factor. So this is about the symptoms. For the this is the next this page is very important because it shows a lot on the exams. So you know that there are changes both on a gross appearance of the heart. This is first, then on the light microscopy, and the complications that occur. Each has a timing, so the timing is very important. You will encounter this a lot of in a lot of questions. So in the first 24 hours, it is divided into the first 24 hours, and from the 1 to 3 days. So in the first 24 hours, you on the gross appearance, this you will see like dark mottling, and there is a pale area of the myocardium, and intervening is the dark mottling of the heart is the first 24 hours. And on the complication level, you will you have sudden arrhythmia, ventricular arrhythmia, VF, VTAC, and sudden cardiac arrest or so. And the patient may have a massive occlusion of the lead and go into heart failure, and may have a cardiogenic shock. This for the complications, acute complication. But on the light microscopy, essentially in the first 4 hours, the heart will have something called wavy fibers in the first 4 hours, and by the 4th hour up to 24 hours, as a patient may have early coagulative necrosis. This is a picture of early coagulative necrosis. Necrosis means the death of the cells. So after 4 hours, the cell content released into the blood, and this coincides with the rise in the troponin, which elevates mostly after 4 hours going up. So after 4 hours, the cell content are released into the blood, and there is edema and hemorrhage. And also reperfusion injury may further complicate that if the patient get streptokinase or got stented, and the free radicals and the calcium will increase in its influx. So increasing in the calcium influx results in hypercontraction of the myofibrils and causing dark eosinophilic stripes. So this for the light microscopy. Again, for the light microscopy, first 4 hours you will have wavy fibers. After 4 hours up to 24 hours, this is the coagulative necrosis, and by necrosis the cell content released into the blood, and edema and hemorrhage. You may get a reperfusion injury. This leads to a free radical buildup and calcium influx. Calcium influx will lead to hypercontraction of myofibrils and dark eosinophilic stripes. So this is the first 24 hours. The first to third day on the mottling here will become a hyperemia. This is for a gross level. For the complication, there is something called post-infarction fibrinous pericarditis, or fibrinous pericarditis, and the other kind of pericarditis called the Dressler syndrome, which comes late. But the early pericarditis is very, very important. Here is the post-infarction fibrinous pericarditis. So it occurs from 1 to 3 days. You have to memorize well the days. 1 to 3 days post-infarction fibrinous pericarditis. For the LM picture, you will have extensive coagulative necrosis, and tissue surrounding the infarct shows acute inflammation with neutrophils. The arrows here point to the neutrophils between the extensive coagulative necrosis affecting the myocardium. So you have essentially two elements: the extensive coagulative necrosis, and the tissues, and the intervening between them is the neutrophils. So from the third day up to 2 weeks, the gross appearance, you will have hyperemic border and central yellow brown. There is hyperemia or the border, but the center is yellow brown and softening, and this is softening is due to the effect of macrophages. So on the LM level you will have macrophages, and the macrophages have the granulation tissues as the margin. So the gross appearance is translated into LM picture. So you have the central yellow brown softening due to the effect of macrophages, and the granulation tissues as the margin, which is transmitted into hyperemic border due to granulation tissues at the margin. This is from the 3rd to 14 days. These are the first 2 weeks after a MI. The complication here due to the macrophages and the weakening of the myocardium, you may have a free wall rupture. Is a dangerous complication that may lead to tamponade, or papillary muscle also may rupture, not only the free wall but the papillary muscle. So this may lead to mitral regurgitation. The interventricular septum may rupture due to macrophage mediated structural degradation, left to right shunt, and you may have something called LV pseudoaneurysm. So in the left ventricle you have not true aneurysm containing all the muscles and all the layers, but it is a pseudoaneurysm bobbing of the myocardium, and this is called the pseudoaneurysm. The pseudoaneurysm it doesn't contain all the layers of the heart, and essentially may also rupture. So from 3 to 14 days, these are the period of ruptures. On a different level, on the free wall of the heart may lead to tamponade, on the papillary muscle regurgitation, on the interventricular septum rupture due to so you have to count whatever structure you may find, and it may rupture. This is due to on the macrophages on the LM picture, and the central yellow brown softening on the gross picture. So this all translates to each other. From 2 weeks to the several months, this is the end result for the MI. The hyperemic border and the central yellow brown softening transfers into gray-white scar. This is finally we reach it to the point of the scar formation. So you will find on the LM is a contracted scar on the LM. No much details. So you may have heart failure. The patient essentially has chronic heart failure, may have arrhythmias all of his life. The patient who had an MI may have arrhythmia at any point of their life. So they may have true ventricular aneurysm. So in contrast to the pseudoaneurysm that occurs in from 3 to 14 days, From the second week ongoing to several months, the patient may end up with ventricular aneurysm that will stay with him for his life. This ventricular aneurysm, not pseudo aneurysm, and may have a mural thrombus with the risk of embolism. So for the diagnosis of myocardial infarction, we have said that cardiac troponin I it is the most specific. So very high yield. The troponin I is the most specific for the heart rises after 4 hours. So it's beginning to rising after this is a 4 hours. This is a 1 day. This is a 1 day point, and this is a 4 hours, and it starts rising to reach its peak about like 24 hours or 1 day. This is the peak of the troponin, and this is very good for the troponin. This is the most specific. It is the first to rise and reach its peak around 24 hours, but the downside, it stayed elevated up to 10 days. This is the 8 days, and it is still elevated. It may continue. May continue rising up for 7 to 10 days. It's more specific. The best is the troponin I, but the CKMB increases a little bit delayed. The troponin I, as we have said, after 4 hours it starts, but the CKMB starts up after 6 hours. After 6 hours, the CKMB starts building up and reaches the peaks also around 24 hours, the same as troponin, but it has very particular said that it goes down again. What is very special about it, it goes down again about 48 hours. So about 48 hours it may go down again and returning to normal. So you may use this very well to diagnose reinfarction. If you have patients that admitted in the ICU and the CKM after 2 days or after 3 days, the patient complains of a chest pain again, and you do CKMB for the patient and withdraw it from their blood, and you find it elevated again, this is a marker of reinfarction. So but for the first 6 hours, you have to depend on the ECG. ECG is the gold standard in the first 6 hours. So if the patient complains of the chest pain that started like 10 hours or more than 6 hours, you may depend on the cardiac enzymes. But in the first 6 hours, there is no absolute guarantee that the cardiac enzymes are elevated, and the patient may have MI and with completely normal cardiac enzymes, so you have to depend on the ECG. The ECG changes include ST elevation, and then STEMI, transmural infarction, or ST depression, and then non-STEMI or subendocardial infarction, as we have explained, may have a hyperacute T wave inversion, pathologic U wave, or a different kind of abnormalities. You have to correlate the ECG changes with the risk factors and the typical symptoms and the cardiac enzymes, and take your decision. Another important topic is the ECG localization of the STEMI. You have different kind of leads that translate into different areas of the heart. So first you have V1 and V2, V3 and V4. These all four leads will translate into anterior, but V1 and V2 and anteroseptal, anterior and septal part, and the V3 and the V4 are anterior and apical. So they are all anterior, but anterior septal V1 and the V2, and anterior apical V3 and the V4. So this is for the anterior. And the lateral part is 1 and the AVL. For the lateral part is 1 and the AVL. So for the anterior part, first the anterior part is transfused through the left anterior descending artery, and the lateral part is transfused through the left circumflex. So this is left circumflex 1 and AVL, anterior descending artery, left anterior descending artery, V1 through V4. So, and the V5 or V6, you have to memorize it as a kind of overlap. So it may be transfused through the left anterior descending or the left circumflex. They are called anterolateral. So they are kind of anterior as these, and they are kind of lateral. So the V5 or V6 is a kind of overlap. So these are the anterior, the kind of overlap, anterolateral, and these are the lateral leads. So and the easy part is the inferior leads, like the L capital. It's 2, 3, and AVF are the inferior from transfuse through the right coronary artery 2 and 3 and AVF. These are the main leads you have to memorize. And thank you guys, and hope to meet again in the next episode.